The 21st question. A 65 years old female with a history of DDH undergoes a THR utilizing a posterior approach. Following THR, she notices inability to dorsiflex the angle of her operative extremity. So there is foot drop after the surgery. The preoperative and postoperative radiographs are seen in the figure A and B. Which of the following operative techniques would have avoided this complication in this patient? So as we all know, in DDH, we have to do femoral shortening osteotomy in order to prevent the foot drop and sciatic nerve injury. Then we can see some risk factors for development of sciatic nerve injury, which are developmental dysplasia, DDH, post-traumatic arthritis, use of posterior approach, lengthening of the extremity. So in DDH, we have to do femoral shortening osteotomy. In uncemented femoral implant, also there is a higher risk of sciatic nerve palsy. You encounter a complication while performing a THR on a 71 years old female through a posterior approach. As you were placing your acetabular retractors may be here in this area. Encountered a brisk arterial bleeding believed to be a femoral artery. So the answer, they are asking about the position, numbered position. So the femoral artery will be going this area, obturator artery will be in this area, sciatic nerve will be in this area. So position 2 is the answer. So we have to understand that we have to divide it into 4 quadrants. It is the center of acetabulum. You have to connect ischial tuberosity and anterior superior iliac spine. Then we have to draw a line perpendicular to this line. This is the anterosuperior area, femoral artery area. This is obturator vessel and nerve area. This is the postero-inferior area. This is the posterior-superior area. Posterior-superior area is comparatively a safe area. So we have to understand that posterior-inferior quadrant has got inferior gluteal nerves and vessels. Femoral artery and associated neurovascular bundle crosses hip joint anterior to the capsule joint at the level of anterior inferior iliac spine. Therefore, is a risk of damage by retractors in this position. Antero-inferior quadrant, obturator nerves and vessels. Posterior inferior quadrant, inferior gluteal nerves and vessels. Posterior-superior quadrant is relatively safe zone for retractors placement. 60 years old man with a history of AF and mechanical aortic valve replacement undergoes the total hip replacement via postoperatively. The recommendation of his cardiology team, he is started on warfarin. 4 days after the discharge, patient returns to emergency department with a 10% drop in hematocrit. So the patient is developing a hematoma. New complete sciatic nerve palsy is also there. His INR is 6, so it is dramatically increased. So we have to do a reversal of INR with vitamin K and plasma, and we have to do an urgent surgical irrigation and debridement. So new wound drainage and nerve palsy is the problem here. So on warfarin there is very much raised INR, so we have to infuse vitamin K and FFP, and we have to surgically decompress the hematoma. "65-years-old male golfer present with right hip pain, 3 years duration, which has persisted despite daily oral anti-inflammatory medication and physical therapy." You can see the image first, so it will definitely need a THR. 67 years old, he wishes to complete a recreational golf tournament in 5 months. Which treatment modality would offer most reliable functional improvement? Not corticosteroid, not hyaluronic acid, not hip resurfacing in this age, not cemented. Uncemented is the treatment. It has got most predictable symptomatic relief and return to function in 5 months. So uncemented is the treatment of choice here. When performing a total knee arthroplasty using intramedullary referencing, knee is stable at full extension. So extension gap is okay. Will not flex past 90 degrees. So there is tight flexion gap. Which of the following adjustment can achieve satisfactory range of motion and stability in flexion and extension? So we have to do the downsizing of the femoral component. So there is an image that will come later. So of the option listed, downsizing the femoral component is only modification that will loosen the flexion gap. Other things we can do is recessing the PCL, increasing the posterior tibial stop. So we have to understand that distal femoral cut affects extension gap, posterior femoral cut affects the flexion gap. Proximal tibial cut will affect both flexion and extension gap, and femoral component downsizing will cause increased flexion gap. We will discuss it later in the same video. Which of the following factors most places a knee at risk of patellar maltracking TKR? So it is one of the most important question. It has been repeatedly asking in the exam. So what are the factors that helps in better patellar tracking? Better patellar tracking, we have to do external rotation of the tibial component, external rotation of the femoral component, lateralization of the femoral component, lateralization of the tibial component, and also, but the only thing that has to be medialized is patellar component. Patellar component should be medialized. Patellar component should be medialized. For a patellar component should be medialized for a better patellar tracking. So external rotation of the femoral component, external rotation of the tibial component, external rotation of, lateral placement of the tibial component, lateral placement of the femoral component. This all helps in better patellar femoral tracking. 72-year-old male represent to the emergency department after he felt a sudden pop in his right hip, the inability to ambulate. Review of his recent lab show cobalt level increased, chromium level also increased. This presenting radiograph shown in figure A. Which of the following contributed to this patient underlying condition? So here we can see that high metal levels in the blood, and also there is, so it is a mechanically assisted crevice corrosion. Usually it is clinically significant trianosis is uncommon. It results from mechanically assisted crevice corrosion at the head-neck junction of the hip arthroplasty patient. In severe cases, trianosis can lead to pseudotuber formation and catastrophic implant failure requiring revision surgery. If trianosis is left untreated, results in ARMD, adverse reaction to metal debris, and alveolar aseptic lymphocyte dominant vasculitis associated lesion. Clinically, the pseudotumor formation typically occurs in two settings. Typically, it occurs in metal on metal articulating hip implants, but trianosis is the other cause for a adverse reaction to metal debris. So in this image, we can see that it is not a metal on metal implant, but trianosis, and due to mechanically assisted crevice corrosion is the cause for high metal level in blood and failure of the implant in this patient. Next question. 67-year-old female complains of anterior groin pain in 1 year following surgery. Anterior groin pain, in every question we have to look for, one thing we have to look for is always iliopsoas tendinitis. So and also the point here, it points towards pain reproduced with the resisted seated hip flexion denotes towards iliopsoas tendinitis. Here, infection profiles are within normal limits, so we have to go for an image-guided diagnostic injection of lidocaine into the iliopsoas tendon sheath. We can also inject steroid into the tendon sheath. So it is a diagnostic and therapeutic modality for diagnosis of the iliopsoas tendon sheath. The malpositioning of the acetabular component is one of the causes for iliopsoas tendinitis. Anterior prominence of the acetabular cup. Anterior prominence of the acetabular cup can irritate the iliopsoas tendon, and this is the image-guided injection of lignocaine or lidocaine into the iliopsoas tendon sheath. It is a diagnostic and therapeutic modality in iliopsoas tendinitis. During TKR, the trial components in place, the knee achieves full extension, but experience tightness in flexion with a range only to 90 degrees. What is the most appropriate action? One thing we can do to increase the flexion gap is increase the posterior femoral cut. After resecting proximal tibia, it will also cause us increased extension gap also. So this is not the answer. Distal femoral augment, it will cause decreased extension gap. Downsizing the polyethylene insert, it will affect both extension and flexion gap. If you are resecting more distal femur, it will cause decreased extension gap. So downsizing the femoral component is the answer of choice in this option. And also we can resect more posterior femoral cut for gaining the flexion intraoperatively. Last question, 30th question. During THR, which of the following techniques increases range of motion prior to the impingement? So larger head means larger arc of motion. So femoral head-neck ratio increases the jump distance. We have to understand that increased diameter means larger arc of motion, larger jump distance, and higher the stability. Head to neck ratio, jump distances, diameter. We have to understand these things.